So I want to welcome today Brian Colwell Jensen, MD, and let me just go ahead and shift the camera here. So Dr. Jensen, welcome. Really
Thanks,
glad
Tim.
to have you here.
Thank you.
And you're going to be talking about cardiovascular toxicities and cancer therapies. We have a little bit of information about you. An associate professor of medicine and pharmacology at University of North Carolina, Chapel Hill School of Medicine, physician scientist with a clinical and investigative focus in heart failure, clinical certification in advanced heart failure transplantation, spends 3 months of the year as an attending physician for the UNC Heart Failure Transplant LVAD inpatient service. And you also direct the UNC Cardio-Oncology Clinic. What else should we know about you? Something from your personal bio in addition to your professional bio.
Yeah, no, as we were just discussing, I'm a Chapel Hill native.
Great.
Basically born and raised here, went to Chapel Hill High School back when there was only one high school in town.
Yeah.
Have 3 kids and happy that it's fall.
Yeah, yeah, it's really beautiful out there. Well, thank you so much for being here. We talked about poll everywhere. This is just a sample slide. We try to make this first one a softball. Cardiotoxicity is a term for any heart damage arising from cancer treatments. So you can say true, you can say false. It's anonymous, so take your best guess. While you're doing that, I'm going to say that, let me pull this up, that this activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Continuing Professional Development. The course director and CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. The University of North Carolina, Chapel Hill is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. The potential conflict of interest occurs when an individual has an opportunity to affect educational content about healthcare products or services of a commercial interest with which she has a financial relationship. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with any commercial interests pertaining to this activity. The presenter has no relevant financial relationships with ineligible companies as defined by the ACCME. That sound about right?
Sounds about right.
Okay, got that out of the way. All right. And we're already getting some answers on that poll everywhere. So we've got a lot of folks saying true, cardiotoxicity is a term for any heart damage arising from cancer treatments, and a small percentage saying maybe not. How are they doing?
Terrific.
Great.
Terrific.
Great. All right. Well, I'm going to go ahead and switch that over, and you're all set. If you do want to use the pointer, there's the mouse there as well.
Great. Well, thanks, Tim, and thanks to everyone who's joining today. I'm really honored to be speaking with you. I am, as Tim said, I'm a physician scientist, but I'm not going to bother you with the science that we do in our lab, though I am interested in some of the molecular aspects that underlie cardiotoxicity related to cancer therapies. I'm talking to you today mostly as the director of our cardio-oncology clinic, and thought that I would start with an introduction to what cardio-oncology is. And so like most people, when I don't know something, I turn to Google, and here's the leading definition for cardio-oncology. It's not a definition that suits me particularly well, and so I think I would like to progress on to say that whatever cardio-oncology is, and I hope to put a little meat on those bones for you, whatever it is, it does appear that there's increasing interest in the field, as evidenced by the proliferation of cardio-oncology clinics at academic centers across the country. I also turn to PubMed when I don't know something, and I update this slide every time I give this talk or a talk related to this topic. And so this is a PubMed search from earlier this week, and I want to draw your attention to 2 things. One is that when you PubMed cardio-oncology, you get 2,904 results. The second thing I want to turn your attention to is that if you were to PubMed cardio-oncology 10 years ago, you would have gotten 13 results. So whatever cardio-oncology is, it's a field of growing interest to people as well. I prefer to think of cardio-oncology in terms of who the patients are, whom we serve in the field. And this is my creation. I think of patients within three different bins here: comorbid patients, patients who have both heart disease and cancer at the same time, either by virtue of shared risk factors or by pure bad luck. There's a large cohort of survivorship patients who had breast cancer in the past, or had cancer in the past, excuse me. This patient in particular had breast cancer, and then subsequently developed heart disease down the road. We're going to talk a bit about some survivorship issues today. In my clinic, we primarily focus on the causal, people who develop heart disease or potentially develop heart disease in the setting of active treatment for cancer. And I think most of the talk today will focus on these particular issues. I'm going to talk initially about some demographic issues that drive the field. Then I'm going to focus on traditional therapies, particularly anthracyclines and radiation therapy. Going to move into some older targeted therapies, and then going to finish by talking about immunomodulatory therapies, and hopefully this will be useful information for you. So few people in this audience need a reminder of the fact that heart disease and cancer are the leading causes of death year upon year in this country. I updated this slide recently to show that COVID-19, as many of you likely know, was the third leading cause of death in 2020 in this country. I want to draw your attention to the curves on the right side of this slide here. Thanks to terrific work that people in the cancer care field are doing, the overall mortality related to cancer in both men and women is declining over the past decade. Unfortunately, in heart disease as a cause of death is rising in both men and women. And one way to maybe overinterpret these data would be that the people whom you are keeping alive by virtue of your excellent care are becoming people who are at risk for death due to cardiovascular disease. I'm going to put a finer point on that as we go. These are old statistics, but as far as I know, they're still accurate. Survivors of cancer, particularly childhood cancer, have a 10-fold increased risk of coronary atherosclerosis, a 15-fold higher risk of heart failure, and a 9-fold increased risk of stroke. There are some risk factors that drive these numbers, and we're going to focus on those as we go, in particular anthracyclines and high-dose radiation therapy. Admittedly, these are somewhat older data, but still relevant these days. I want to focus on two particular disease groups for a moment. First, breast cancer patients. Many people are interested and somewhat surprised to see that amongst women who present with early stage breast cancer, the more likely cause of death is cardiovascular disease than breast cancer. And again, this is a testament to the excellent care that these women get for their breast cancer. A couple of things to draw your attention to on this slide regarding Hodgkin lymphoma. The first is the summative risk of exposure to mediastinal radiation and anthracyclines for the treatment of this disease. The second is the fact that by 25 years after treatment, and again, considering that many of the people who received this treatment were children, by 25 years after this treatment, roughly 40% of survivors have developed cardiovascular disease of some sort. And again, considering that there were people who were kids at the time, we're looking at a significant number of patients who are in their 30s, 40s, and 50s who are developing cardiovascular disease in an accelerated fashion. With respect to the traditional, more cytotoxic therapies, particularly anthracyclines, as well as radiation therapy, there are established ways to identify people who are at particular risk, and little surprise, that risk estimation hews to the traditional risk estimation that we make for cardiovascular disease, with comorbidities like hypertension, diabetes, high cholesterol, and a family history, markedly increasing the risk for developing cancer therapy-associated cardiotoxicity. The risk stratification is less clear for targeted therapies, in particular for immunomodulatory therapies, as we'll discuss later. So that brings us to the first question, which is, which of the following can be caused by radiation therapy?
Again, completely anonymous, so take your best guess. Thank you all I see a lot of folks jumped right in and are answering this, so thank you. Dr. Jensen, seems like we're hovering on
no,
E.
that's right. And these are not intended to be gotcha questions. All of the above is always appealing, but very well done. All of the above, E is indeed the answer. So going back again to this cohort that I presented earlier of patients who underwent treatment for Hodgkin disease and received mediastinal radiation, you can see below the hazard ratios for any cardiovascular disease, but then broken down into coronary artery disease, valvular heart disease, heart failure, which largely arises from a restrictive cardiomyopathy. They don't include pericardial disease, but that clearly is increased in incidence after exposure to radiation therapy with the heart in the field. Another disease group, just to reinforce the point here, this is a nice study from the New England Journal of Breast Cancer Patients in Scandinavia, showing a pretty clear dose-response relationship between exposure to radiation with the heart in the field in the left panel, and then on the right panel showing the interaction between that dose-response risk increase and the presence of cardiac risk factors, which we discussed previously. I'm not going to go into mechanisms here. I'm going to use the time afforded by having this slide up to say that the mechanisms are incompletely understood. I think that the most unifying injury is probably to endothelial cells, but a whole lot more work needs to be done on the basic level to understand why radiation therapy causes the diffuse damage that it does. I also want to use the opportunity now to say that thanks to advances made by people like Larry Marks here at UNC, that the incidence of radiation therapy related heart disease is decreasing over time as we learn about heart sparing techniques. But for those who have been exposed in the past, if there's any message to convey, and this is with respect to the survivorship cohort that I mentioned earlier, it's that we all should have an increased index of suspicion for heart disease in otherwise younger and otherwise lower risk patients who have had exposure to radiation therapy in the past. There are some risk factors related to treatment. Again, the cumulative dose, as I showed before in that Scandinavian breast cancer study, the cumulative dose is certainly a risk factor. Interestingly, younger patients and the amount of the dose per fraction that's received. Other than that, the risk amplifying factors are, again, the comorbidities that we discussed previously: hypertension, diabetes, high cholesterol. And there's some interesting work going into defining whether modifying those risk factors up front as patients are exposed to necessary radiation therapy, whether that will downstream reduce the risk of heart-related complications. And that's also work that's going on in the radiation oncology group here currently. This is, again, none of this talk is intended in any way to impugn the therapies that are used to treat cancer. It's clear that they're used for very good and outcomes-related reasons. Choosing breast cancer in this case, radiation therapy in this Lancet study clearly prolonged survival. I think that the point that I would hope to make with a slide like this is that the all-cause mortality difference is attenuated somewhat, and it's conceivable that the attenuation of all-cause mortality benefit is due to an increased risk of radiation-related heart disease. Again, just an encouragement to all of us to keep our eyes open clinically to the possibility that people who have been exposed in the past to radiation therapy are indeed presenting with cardiovascular disease now, despite being otherwise at relatively low risk. I'm going to transition away from radiation therapy and turn now to anthracyclines. Again, this is a topic with which I'm sure all of you are familiar. Anthracyclines broadly used in many tumor types and still broadly used in many tumor types. As with radiation therapy, the risk of developing cardiac toxicity, and here the toxicity is almost entirely myocardial, so there's very little in the way of vascular or valvular toxicity related to anthracyclines. That cardiotoxicity is driven largely by comorbidities, though affected by exposure, as we'll talk about shortly. I'm going to skip this slide. This is not background information that anyone in this audience likely needs. But I do want to spend a bit of time talking about the dose-related. I use dose-dependent here. I think dose-related is probably a clearer way to state this issue, that anthracycline cardiotoxicity is indeed a dose-related phenomenon. Looking at panel A up here, you can see that the sharpest upturn or inflection point in that risk curve does occur at the threshold that most of us consider the threshold for risk at 250 milligrams per meter squared. But I want to draw your attention to the fact that at lower dose exposures, there still is substantial increased risk for developing cardiomyopathy and heart failure. And indeed, in clinic, I routinely see people who have developed cardiomyopathy in the setting of contemporary anthracycline doses at exposures lower than the 250 milligrams per meter squared. This is an old figure from an old Annals paper, and I've used it very intentionally because the conception of anthracycline-induced cardiotoxicity as a delayed onset problem is a bit outdated. That in general these days, and I'll show you some data to support this claim, in general these days, the understanding is that most of the damage and hence risk occurs up front, which makes sense biologically, and that the late onset cardiomyopathy that was considered previously, as in this Annals paper, largely arose from a failure of adequate surveillance and screening early on after treatment. So a number of different studies have demonstrated this. There's an echocardiogram study and an MRI study. On the bottom left is a figure from a paper that I published with some folks here in collaboration with the Winston-Salem group. Collectively, they demonstrate that actually a decrease in ejection fraction or contractile function in the heart after anthracycline exposure is really the rule rather than the exception, that most patients who have anthracycline exposure do drop their EF or drop their contractile function early on when receiving anthracyclines. And from a mechanistic standpoint, this is probably related to cardiomyocyte atrophy more than cardiomyocyte death, as historically been thought to be the case. These diminutions in contractile function, as you can see, are relatively mild, and most people do recover from them. But again, the point here is that anthracyclines are tough on the heart early, and at pretty much any dose. This is a somewhat dated slide from an Italian group that studied this issue extensively. These findings have been replicated since that time in other data sets. And the point to make here is that if we identify anthracycline-induced cardiotoxicity early and initiate treatment with cardioprotective therapies, in this case ACE inhibitors, though beta blockers have been studied as well, the likelihood of response and recovery of EF goes up significantly, whereas if we identify the insult later, the likelihood of recovery is lower. And indeed, before I move on to this slide, I'll say that a certain percentage of patients, and I think at this point it's fair to say this percentage is poorly defined, historically considered roughly a third, probably better than that. A certain number of people will have early diminution in their ejection fraction and then recover spontaneously without any therapy whatsoever. But the likelihood of recovery is clearly enhanced by institution of cardioprotective medications. So I'm posting the guideline harmonization from 2015, published in Lancet Oncology, and calling out the guidance on the right-hand side. But you can see with an asterisk there that echocardiogram within 6 to 12 months, and 2 years after treatment, and every 5 years thereafter. I think, as you see the next iteration of these guidelines or similar guidelines published, you're going to see much more attention to early surveillance with echocardiograms. And I would encourage all of you who are providing active care and doing early post-anthracycline follow-up to consider adopting this approach rather than waiting. That early echocardiograms within 6 months after completion of anthracycline exposure is going to find more people, and that because early detection improves outcomes, those people will do better in the long term. Trastuzumab, now we're transitioning from older therapies and beginning to discuss targeted therapies. Admittedly, trastuzumab's been around for 20 years. I think HERA was 2003. Again, don't need to introduce the molecular basis of trastuzumab's action to anyone here. But I will say that this is part of what got me interested scientifically in this field, that the preclinical studies of trastuzumab really didn't call out the risk of cardiac toxicity that we've seen in the post-marketing world. The mechanism here is not entirely worked out. It results at least in part from impaired crosstalk between endothelial cells and cardiomyocytes and blocking beneficial signaling through neuregulin-1, but certainly that's not the only mechanism that accounts for the cardiotoxicity of trastuzumab. And at the bottom of this slide, I'm quoting 3 to 27% of patients treated with Herceptin developing cardiomyopathy. I think I'll, in a second, put a clinical trial number up that will resonate there as well. It's frequent. It happens a lot. I see quite a bit of it in clinic. It's not dose dependent. It doesn't obey in the same way the risk stratification for comorbidities that anthracyclines do, although it's clear that either concomitant or these days more likely sequential exposure to anthracyclines and HER2 antagonists does increase the risk for cardiomyopathy, which again, thankfully, is usually reversible and usually not associated with clinical evidence of heart failure. There are data that I'm not showing that suggest that using cardioprotective medications when patients drop their EF on HER2 antagonist does increase the likelihood of recovery, but those clinical trials are harder to do because many women, primarily women who receive these agents, recover their EF regardless of whether they're treated or not, and it's really a matter of time and withdrawal of the HER2 antagonist. This is a clinical trial that looked at whether or not we should use ACE inhibitors or beta blockers for primary prevention. And I won't read all of the numbers here to you, but I want to call your attention to a couple of things. The percentages in the groups in the bottom 6 rectangles are the percentages of patients who developed cardiomyopathy on treatment. And these are not small numbers. Again, the majority of these were mild decreases in EF, and the majority were not symptomatic with heart failure. But these are big numbers. It's clear that the risk is increased by anthracycline exposure, and if there is a benefit to primary prevention use of ACE inhibitor or beta blocker, it's only in that group. I'll have to say that there's not been a lot of uptake in the field of these particular data, but it's still worth considering in patients who are at particularly high risk for developing cardiotoxicity. This is an old slide, this flowchart for managing trastuzumab and the potential for related cardiotoxicity really has not been updated. The bottom line is that guidance says to get an echocardiogram every 3 months, and that you should continue treatment with trastuzumab unless the ejection fraction drops below 45%, or somebody develops symptomatic heart failure, or there's a greater than 10-point decrease in EF. And so again, the motivating philosophy underlying this approach is that it's clear that interrupting HER2 antagonist therapy compromises outcomes, and I think that's recognized by everyone in the cardio-oncology field. And so the purpose is by no means to interrupt the therapy any more than is absolutely necessary. And so with the exception of those scenarios that I described, the intention is to continue trastuzumab and sometimes along with cardioprotective medications until completion of therapy, at which point in time, once the ejection fraction normalizes, which it almost always does, then the cardioprotective medications can be withdrawn. And there's no signal that there's an increased risk of long-term heart failure or cardiomyopathy in that subset of patients who do develop on treatment cardiotoxicity. I'm going to skip this in the interest of time, though I'm happy to talk about endocrine therapy if anyone has questions at the end. There are just 2 slides on this topic. So we're going to talk about kinase inhibitors next, and here's your next question.
Go ahead, just in case your font is really small and you're trying to view
Cool.
on a phone, which of the following is the most common adverse cardiovascular effect of kinase inhibitors targeting the VEGF signaling pathway? So A, coronary artery disease, B, pericarditis, C, arrhythmias, D, heart failure, E, hypertension.
Yeah.
How are they doing?
They're doing great. They're doing great. And this is an unfair question in some ways, insofar as the many kinase inhibitors that target the VEGF signaling pathway also target other kinases and are not necessarily called out as VSP inhibitors. Nevertheless, the answer is indeed hypertension. So I could talk about idiosyncratic toxicities related to various kinase inhibitors for another entire hour. The association between ibrutinib and atrial fibrillation, for instance, is vexing. I wanted to focus on a class of medications, though, that has a pretty predictable, reliable, and sometimes frustrating adverse effect, which is drugs that target VEGF signaling. Again, an intuitively appealing and highly effective target. Many tumors require angiogenesis to proliferate, and VEGF is one of the key mediators of that process. And targeting the VEGF signaling pathway clearly improves outcomes in many tumor types. This is a dated slide. There are probably 3 times as many drugs that I could add here as well. And again, some of these drugs are relatively focused on the VEGF signaling pathway. Avastin or bevacizumab is probably the best example, whereas others have some anti-VEGF activity, but also are multi-targeted in many ways, and there are a list of those at the bottom right here. Hypertension is very common as a result of these agents. I again call out bevacizumab here. In this relatively small study, the incidence of hypertension was 68%. It's not quite that high in all studies, but it's certainly high enough to catch our attention. Indeed, the degree to which hypertension is induced is a predictor of response in renal cell cancer, which is something. This is a position paper from the European Society of Cardiology, again, listing in the third column here the incidence of all grades of hypertension related to these agents. Not a rare problem in any way. The treatment approach, there is a guideline for treatment out there that calls out calcium channel blockers such as amlodipine as being first-line treatment for VSP inhibitor-induced hypertension. That's my practice in clinic. I cannot say that practice is guided by extensive evidence, but certainly a reasonable place to start. Unfortunately, many of these patients end up requiring multiple agents to control their blood pressure. Here's the sort of expert consensus guideline for treatment here. Not a lot more here other than what I've discussed already, but certainly happy to entertain questions on this topic at the end. There are indeed multiple modes of potential cardiovascular toxicity. There is some direct myocardial toxicity, so those who answered heart failure to the first question were not incorrect. It's just that it's less common from these agents than hypertension. So let's move on to the next one, and now we're transitioning into immunomodulatory therapies. So the question here is, which of the following is the most concerning cardiovascular adverse effect of immune checkpoint inhibitors? Coronary artery disease, A; valvular heart disease, B; myocarditis, C; hypertension, D; or cytokine release syndrome, E.
All right, and if you'll take maybe 5 more seconds. How are they doing?
They're doing great.
Yeah.
The majority of them are correct, and the other answer was my other plausible distractor, and we're going to talk about cytokine release syndrome later. So the answer is indeed myocarditis. So checkpoint inhibitors, again, as this audience knows better than I do, are incredibly effective in many cases, widely used, and their application is only expanding, it seems to me, by the month. They are in general well tolerated. I'll show you a list of other adverse effects in a minute, but going to focus here on myocarditis. So the myocarditis is a topic that's actually been in the news quite a bit in the past year or two as COVID and other viruses can induce myocarditis. Myocarditis in general involves infiltration of immune cells into the heart, where they cause damage directly to the heart muscle itself. And the clinical manifestations of myocarditis can range from relatively rare chest pain in the absence of significant myocardial damage to much more severe arrhythmias that can be life-threatening, heart failure that can be life-threatening. And I want to talk a bit about how we distinguish the mild from the more significant and what we do about those who have more significant involvement. So that the pathobiology of checkpoint inhibitor myocarditis, like many of the other adverse effects related to checkpoint inhibitors, involves clonal expansion of lymphocytes. And again, this is an on-target effect. It's a predictable effect of a checkpoint inhibitor. The reason that these lymphocytes infiltrate the heart in some patients and not others is not entirely clear, though I'll show you some evidence in a minute that implicates CTLA-4. So this is a slide I talked about before. So I like this slide on the upper left very much. It is a look at reporting, post-marketing reporting of immune-related adverse effects, and it lists those adverse effects, as you can see, and it lists them in terms of frequency and in terms of case fatality. And to contrast something like colitis, which is highly frequent but rarely fatal, myocarditis is rare, less frequent, but more often fatal. So a case fatality that approaches 40%. Now, admittedly, these numbers are interdependent to some extent. I think that it's probably more accurate to say that incidence is 1 or maybe 1 to 2%, and that some of those cases are milder, and so the case fatality is probably a bit lower. But the point remains that this is a low frequency but potentially very serious event. There's not much out there that helps us to discern who is more likely to develop checkpoint inhibitor myocarditis. There's a little bit of data suggesting that older women might be at risk. For what it's worth, the last person I saw in my clinic who had this problem was 42. So I think that we need more information before we can define in advance who is at risk for developing checkpoint inhibitor myocarditis. So the take-home message here is, despite the fact that this is a low-frequency event, that I do think it's important to maintain a high index of suspicion because, again, it can be quite serious. So patients who present with complaints that could be referable to cardiac problems, shortness of breath, chest pain, palpitations, syncope, near syncope, those complaints should be evaluated, and the easiest way to do it is with blood work, looking for troponin or high sensitivity troponin. In parallel, some imaging evaluation, certainly if the results are positive, is warranted. An echocardiogram is the easiest to obtain. Gold standard is probably cardiac MRI, but even here at UMC, it's not easy to get a cardiac MRI within a time frame that's reasonable for making a judgment about treatment. An EKG certainly can be quite helpful in this case as well, where the hallmark of myocarditis tends to be diffuse ST segment elevations. It's not a sine qua non. Myocarditis can exist in the absence of these EKG findings, but those EKG findings in the setting of a patient taking checkpoint inhibitor should be taken seriously. So there's not a lot of evidence about how we treat this problem, as you might imagine, given the relative infrequency with which it occurs. In general, though, it's quite clear that if a patient develops myocarditis on checkpoint inhibition, that the treatment should be stopped. And in almost all cases, probably should not be reinitiated. Again, the re-challenge with checkpoint inhibition is thought to be associated with increased risk of recurrent myocarditis. Current treatment emphasizes glucocorticoids, so high-dose Solu-Medrol up front, prednisone taper thereafter. This is largely extrapolated from treatment of myocarditis and actually allograft rejection of heart transplants. And then, of course, hemodynamic support and treatment of heart failure in the more advanced cases. I'm going to detour briefly into some work that was done by a friend of mine, Javed Moslehi, along with the great Jim Allison. This is mouse model work looking at a potential new way to treat checkpoint inhibitor myocarditis with a compound called abatacept, which is a IgG for CTLA4, which is one of the immune checkpoints, again, as this audience likely knows, and seems to be one of the primary drivers based on this mouse study of myocarditis in mice. And so what they've done here is they didn't use checkpoint inhibitors, they used heterozygous mice with knockdown of the checkpoints and then expose them either to abatacept or vehicle treatment. And as you can see, abatacept was associated with significant survival advantage in those mice who received it. This has led to a thought in the field that perhaps we should change the way we approach checkpoint inhibitor myocarditis. And this is a proposal. This is not data-driven, and these are early days. But the newer paradigm calls for earlier institution of steroid-sparing agents, such as methotrexate here. We have used Cellcept recently here as well, or mycophenolate. And then for more severe cases, that early institution of abatacept could be used as well. And there's a randomized clinical trial that's opened called Atrium, and this is being run out of the Mass General. And we have just opened here for recruitment. And so the trial design is to randomize patients to abatacept early on for treatment of checkpoint inhibitor myocarditis. And so obviously very interested in seeing these results, and certainly happy to hear from anyone who has a patient who may have developed checkpoint inhibitor myocarditis. I want to close by talking about CAR-T. When I give a talk like this to the cardiology audience, I include a slide where I describe CAR-T and its development. I've omitted that slide for this group and instead turned directly to what many people consider to be one of the most dreaded complications of CAR-T therapy, which is cytokine release syndrome. And cytokine release syndrome is exactly as its name implies, a systemic problem driven largely by the release of cytokines from macrophages chiefly. This is not a problem that seems in any way to be driven by the sort of traditional cardiovascular risk factors that we've described. On the other hand, it's quite clear that people who have pre-existing cardiovascular disease, particularly significant coronary artery disease or decrease in left ventricular ejection fraction or heart failure, those people tolerate CRS much worse. And so in advance, the risk calculation for whether or not someone is a candidate for CAR-T from a cardiovascular standpoint has less to do with whether the likelihood that they would develop CRS and more to do with an assessment of how they would fare if they did. There are also some interesting data suggesting, that's the next slide, that this is a nice paper from a couple of years ago that helps to understand risk related to CRS. And here the risk appears to be entirely driven or largely driven by whether or not patients have troponin elevation, which surely is a surrogate for their underlying cardiac condition, their cardiac fitness, if you will, and that those people who do develop grade 2 or greater CRS and who have evidence of elevated troponin may well benefit from use of an IL-6 receptor antagonist, TOSI, and this is because, as I showed on the previous slide, IL-6 is really one of the chief drivers of CRS. Again, so worth considering if your patients are unfortunate enough to develop severe CRS in the setting of CAR-T therapy. There are some data that suggest that perhaps the cardiovascular toxicities of CAR-T are not limited to CRS. And here is a list of various cardiovascular problems that seem to occur at higher frequency in CAR-T patients than controls. And probably not a surprise given the importance of inflammation and cytokines in the pathogenesis of cardiovascular disease. But I think these are early data and it's hard to know what to do with them other than to simply be aware of the possibility that these issues could arise with CAR-T. I'm going to close in just a couple of minutes with a really fun project that we have undertaken here. Just an example of how cardiology can be interpreted from a research standpoint. This is not from my lab, this is clinical research. So this is an issue that many of you are familiar with, the monitoring of the QT interval with any number of not only drugs that are used to treat cancer, but drugs that are used to treat the adverse effects that can arise from the drugs that are used to treat cancer, all of which collectively can conspire to increase the QT interval in patients. And just as a reminder, the reason that we worry about QT prolongation is that significant QT prolongation puts a patient at risk for sudden cardiac death related to polymorphic ventricular tachycardia or torsade de pointes. So our group got interested in this a couple of years ago, and this is led by Josh Seidner, who's primarily a leukemia doc here. And the interest arose from Josh's clinical frustration with the need to monitor QT interval and the question about how to do so best. And so this was a JCO sort of extended editorial that we published a number of years ago. And then we followed on that with a publication more recently that was led by Daniel Richardson with Josh Seidner as the senior author. This is from JAMA Oncology recently, and I was really proud to be a part of this. So this was a thoroughgoing look at, as you can see, almost 20,000 EKGs from almost 7,000 adult cancer patients at UNC. And the question that was asked was, does the choice of the QT correction formula, where you correct the measured QT interval to the heart rate, does the choice of formula impact clinical outcomes in cancer patients? And so there are a number of figures. I'm going to share only one. Suffice it to say that there are three different formulae for calculating the corrected QT interval. The most common one, by far, is the Bazette formula, and that's shown in panel C down here. And in these almost 20,000 EKGs, if you used Bazette to monitor for the QT interval, corrected QT interval, and you were looking for a grade 3 CTCAE, which could lead to discontinuation of therapy, that occurred in about 9% of the cases with Bazette. You contrast that with Framingham or Fridericia, two other and more accurate QT correction formulae, and that number drops considerably to 1.8 or 2.7%. And there's a really nice figure, I think, in panel D that shows the extent to which those two more accurate formulae reproduce one another, whereas the Bazette formula has a clear tail that's an outlier. And the paper goes on to discuss the potential impact, or identify the potential impact of this discrepancy in cancer patients here at UNC. So again, lots of fun and something that I was really proud to be a part of. These are my take-home points. Cancer and its treatment increase the risk for subsequent cardiovascular disease. Radiation therapy has numerous durable adverse effects on the heart. Anthracycline cardiotoxicity occurs early, and again, just an encouragement to institute surveillance echocardiograms earlier than has historically been done. Please keep a high index of suspicion for checkpoint inhibitor myocarditis. Though it's rare, it can be fatal. And where possible, use the QT Fridericia or Framingham as the QT correction formula rather than Bazette, because it can have clinical impact. That's all I have for you, and I welcome any questions, and I do thank you for your time.
Great, Dr. Jensen, thank you so much. Talking about radiation therapy, what's the role of surface-guided radiation therapy in terms of patients with cancer in the left breast and reducing toxicity?
Yeah, there are a number of what feel like intuitively obvious means to reduce the risk of means to institute heart-sparing radiation therapy. Mm-hmm. Surface-guided being one. Brett, mm-hmm. Those are all. We don't need those.
Sure, I'm just going to forward so they can see our question slide.
Okay.
There we go.
The other one that is really obvious, appealing, and really effective is breath hold. And I have some slides that Larry Marks shared with me showing the extent to which just a breath hold inspiration can remove the heart from the field in many cases. So I think there's a lot of thought that's gone into these problems out of the group here at UNC and elsewhere. And so a lot of progress being made.
Great. All right. We've got a first question. Keep those questions coming, please. I'll let you take that first.
Yeah, so the question is, for anthracycline-induced cardiotoxicity, do you have a target dose? And should both agents be started together or alone? I want to answer that. I want to start to answer that question by acknowledging that, particularly for people who are actively on treatment or have recently been on treatment, it is not always easy to get them on drugs that lower their blood pressure, or in the case of beta blockers, might make them feel a little bit more lethargic than they always do. And so, despite the fact that there are data that combination therapy are beneficial, I tend to start an ACE inhibitor because there's the most consistent and largest evidence base for the use of ACE inhibitor. And for heart failure, the target dose of ACE inhibitor varies by drug. Lisinopril, it's 20 milligrams, and enalapril, it's 10 milligrams twice a day. And I rarely get this subgroup of people to those target doses, but I will try. And so the shorter answer is titration is tolerated, and that some is better than none.
All right, and we've got another one.
Yeah, so is there association of arrhythmias with anthracyclines after induction? Yes, there is a relatively smaller subset of people who have an arrhythmia-predominant acute presentation, and that can be either atrial or ventricular arrhythmias. Thankfully, that is a relatively smaller subset of patients than those who present with decrease in contractile function.
Great. And I don't see any other questions yet. I'm going to go ahead and cover a little more information to wrap things up, and then we'll go back and check and see if we've got any final questions. We want to say our thank yous first and foremost to you, Dr. Jensen. Thanks. This has been incredibly informative. Thank you for your time and expertise today. We want to thank the people of North Carolina for their generous support of the UNC Lineberger Comprehensive Cancer Center and the what we call UCRF here, the University Cancer Research Fund, which funds so much of this important work. We want to thank the team here with the Cancer Network, Veneranda Obore, John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, Patrick Muscarella. They do a lot of work behind the scenes to make this happen, so thank you to all of them. And it does look like we've got a couple of questions that just came in, so let me come back here and let's look at those. We've got just a minute to take those. One should be popping up. I'll read it because it's having a little trouble populating. Do you know of any studies that look at exercise alone without ACEI, there it goes, or beta B as a preventative or treatment measure for decreased EF? Has that been shown to be effective if there are studies? Great question.
So there have been a number of studies in this area, some of which actually have come out of the Get Real and Heal group here. In general, exercise is clearly beneficial in this patient population, improving quality of life, improving functional status. There's not a clear signal that exercise alone can improve ejection fraction, but again, ejection fraction is not the only important endpoint for these patients, to be sure. So I absolutely encourage exercise as part of the recovery from anthracycline-associated cardiotoxicity.
Great. And then this one last question we'll take.
Yeah, so pericardial effusion management is related to do we medically manage as long as possible? When do we get the procedural? Yeah, so this is a tough one. Certainly, if the echocardiogram suggests that there is evidence of tamponade, so if the right atrium or right ventricle are in any way compressed by the pericardial effusion, even if the patient is clinically stable, I think it's reasonable to bring in a interventionalist to consider whether pericardiocentesis would be merited. I also, I tend to follow these effusions with echoes with frequencies that are tuned to my sense as to how rapidly they're developing, so that the more rapidly they're developing, the more frequently we do echoes. But there does come a time for some patients who have had 1.5 or 2 centimeter effusions for 2 months and are clinically stable, but we just decide not to take the chance, and that pericardiocentesis is a relatively low risk procedure. And as often as not, I have had patients who thought they were asymptomatic with their pericardial effusion feel a whole lot better after it was evacuated.
Thank you all for those great questions. Thank you for your time here.